Hey everyone, good evening. This is Dr. Sullivan. We are here for another lecture of I Care for Your Brain. I am a board certified neuropsychologist and I have been doing this for over a year now, weekly lectures. And the whole point of being with you is to give you high quality science-based information and empower you, because one of my beliefs is that a layer of pain and disability that comes from brain health challenges is a lack of information a lack of access, to really good, high quality information. Unfortunately, the way our medical system is changing, you are getting less and less face time with your doctors. And especially the issue we're gonna be talking about tonight, essential tremor, is not well understood at all. And what that means is that you, as a person living with it or loving someone who's living with this condition, is you have to be highly educated. You have to be on top of all the latest research that's coming out because it's changing very fast. And across all brain issues, I encourage people to be their own best advocate. But I really think the more I learn about ET, the more it is really, really, really important with this condition. So we are doing a new series on I Care for Your Brain called an article review. And basically, it's me looking at the scientific literature. Hundreds of articles are being written every single month about different neurological conditions by the most brilliant academic minds that we have. But guess who is reading them? Other brilliant academic minds. My job is to try to make this information more accessible to you as a person living with these conditions so you can do that advocacy that we both believe in so much. So I want you to listen tonight with an open mind, an open ear. We're going to be talking about some of the history of how we have classified and diagnosed essential tremor, where they've gotten it wrong in the past, how they're recently making some changes to the classification system through an international task force to try to improve it, but why a group of researchers are really feeling strongly that we're still not getting it right, and we still have to acknowledge that patients are having a ton of symptoms that are very real, but that we just don't yet understand as clinicians. And this is a problem because people are out there not being validated, not being believed, being classified as having one type of movement disorder, when really the truth is it is the Wild West out there within the world of tremor. There's so many syndromes, there's so many contributing factors, and there's a lot of heterogeneity, especially within essential tremor. That is known, but what that means is sometimes you might go to a provider and be talking about something, and a lot of the things I study as a neuropsychologist, the non-motor symptoms, we've talked about on here, trouble with word finding, trouble coordinating and managing mood. And I know a lot of you have enjoyed my lectures because you know that you're living through this, but your doctors are like, no, I don't think so. I think that's depression. I think that's anxiety. Well, guess what? You're living with it and you're the best person to have the answers to that question. So I do these lectures because I want you to have a direction to these original sources, these original articles. So I'm going to be posting the two that I'm going to reference tonight in the comment section when I am done. So if you are new to this program, you can go back into our archives, and I have done in the past 2 lectures on essential tremor and really tried to focus on those motor, non-motor symptoms, especially the things that are kind of under the surface that you can't see, that aren't as visible as tremor. And then I did one where we focused on all the cutting edge interventions that are happening now, like focused ultrasound and gamma knife and deep brain stimulation. So if you're interested in that stuff, head on back to those old lectures. So as many of you know who are watching me, essential tremor, or ET, is a very heterogeneous neurological condition that causes involuntary and rhythmic shaking of the body. It can occur in almost any place in the body, but most typically the trembling happens in the hands, especially when people are doing things like drinking from a glass, buttoning buttons, trying to do your shoelaces. About 90 to 95% of people with ET have the tremor in their hands and in their arms, but about 30% of people we think have it in the head, about 10 to 15% in the legs, and about 5% of people have it in their core in the trunk. The age of onset varies dramatically. There are children, toddlers who have been diagnosed with this. There are older adults who get a first-time diagnosis. The symptoms vary a lot in the course of a day, and there are known exacerbators. So things like emotional stress, fatigue, alcohol, drugs, medication, temperatures, caffeine. And even though long periods of stability are possible, the unfortunate reality is that essential tremor always gets worse over time and eventually affects more of the different body parts. And we think that this especially gets worse in older age, over the age of 65. And this is probably because there are other contributing factors that add into tremor. Tremor itself is actually a very, very common visible symptom, but has many, many, many different causes. I mean, we're talking like almost 100 different possible causes in the brain and in the body, especially things like medication effects. And when you get older, you just take a lot more medication, so you're more likely to have tremor, medication impacted tremor, but also things like the aging of the brain and the subcortical part of the brain that controls a lot of the starting and the stopping of movement. ET is really not that well understood, but what we do know is that there is a part of the brain that is particularly affected, and this is the cerebellum. And this is what I've done a lot of my talks on in the past, because I understand the cerebellum pretty darn good. It was one of the things I focused on during my board exams. And what a lot of people don't get about the cerebellum is that it's not just there for balance and the control of fine movements. This is how it's been stereotyped throughout the understanding of the brain for many years, up until just even 20 years ago. And there was a doctor in Boston, Dr. Schwalman, who came out with this idea of cerebellar cognitive affective syndrome. And he helped us understand that it does so much more than just control the fine movements of the body. We really think of it like the great modulator for everything, the smoothness of things, the smoothness of finding our words, the smoothness of our mood, the smoothness of our irritability. There's so many different things that the brain, the cerebellum in particular, has to do to kind of make everything come together in these very organized ways. That is the problem with essential tremor. And so we know that there are reciprocal connections from the cerebellum to the brain stem and the frontal lobes. And it's the frontal lobes being indirectly affected with ET where we see a lot of the non-motor symptoms. So if that interests you, go back to my old lectures, because that's what I really focused on. The biggest challenge with ET, as many of you know, is getting the diagnosis right. And the biggest one we have a hard time separating it out from is Parkinson's disease. So we've got ET and we've got PD. ET is 8 times more common than Parkinson's, and one of the general ways that we tease these two apart is how did the tremor start? Stereotypically, ET starts more bilaterally, so let's just say in both hands, and is primarily seen during action. It is an action tremor. So this is when you go to do something, when you go to write, when you go to eat, this is when the tremor comes out. Or if you're holding it, like you're standing up and you are holding an object against gravity in your hand, that's when you're most likely to see it. In contrast, Parkinson's is more likely unilateral, so it starts in one hand rather than the other, and over time it does progress to the rest of the body, one side going to the other, and it is more commonly a resting tremor. So this is, sometimes they used to call it a pill rolling tremor, so someone who has their hand at ease and they're just kind of moving back and forth like that. When they go to do something, that's when their tremor is less evident. There are 2 types of ET as we think of it today. We have the familial type, which is due to a genetic mutation, although this genetic mutation is not known yet. It is an autosomal dominant disorder, so if you have a parent who has ET and you have inherited that defective gene, you have about a 50% chance of getting ET yourself. We don't know what causes the genes of ET to turn on. That is a huge focus of neuroscience research today. And if we just knew what that was, boy, we would have such a big leg up. But what I really want to emphasize here is that we have so many unanswered questions. Yet, the way we talk about ET, we do call it the most common neurological disease. We call it essential tremor, right? Suggesting that what is really going on is a tremor, which kind of minimizes the non-motor symptoms. So we actually have kind of this illusion of understanding on one hand, but really when you get into the science of it, there are vastly differing accounts from patients. People's symptoms change over time. But I think part of the problem in medicine today is the label that we've given it makes it seem like, oh, we have this in the bag, we completely understand what this is. And what I worry about as a patient advocate is that you all are out there going to your neurologists, your primary care doctors with symptoms, and they're being invalidated because they don't understand, because the field doesn't really understand yet. So that is the intro that brings us to the first article that I want to talk to you about tonight, and it's called What is Essential About Essential Tremor, a Diagnostic Placeholder. And this comes from a Dr. Fasano and his colleagues, and they are from the Toronto Western Hospital, University of Toronto, and the Department of Neurology at the University of Cincinnati. And they put out what we're calling a viewpoint article, what the journal is calling a viewpoint article. And this was inspired by a research article, a consensus article that came out previously. And they both are out in a journal called Movement Disorders. And this is put out by the International Parkinson's and Movement Disorder Society. So they published this journal. And what happened was a few months ago, Dr. Bahata and his colleagues put out, they reported on the new consensus statement that came out classifying tremors on behalf of something called the Task Force for Tremor of the International Parkinson's and Movement Disorder Society. That's a lot of words there. But basically, the article I want to talk to you about tonight is a commentary on the consensus statement. So obviously, I have to tell you about the consensus statement before we can get to the critical points of the article I want to talk to you about. But all of this is very interesting, I promise you. And I think that, again, I just hope that it helps illuminate some areas of maybe your disorder that you haven't quite understood before. So the name of this is the diagnostic placeholder. So what do they mean by that? They're basically saying the term essential tremor is fine for now because this is what people know. This is the term people use when they want to find a support group, but it is not adequate. It is not sufficient. It does not adequately describe, when you look at the diagnostic criteria, and we're going to go through what the new criteria is in a minute, it doesn't get it. It's not capturing it. It's not complete. It's not comprehensive. So they say, you know, this is fine for now, but we cannot close this chapter in our understanding of this tremor disorder. It really is a very thought-provoking piece, and I will post the original article when I'm done. So let's talk about what this consensus statement is, and then we'll get to some of the critiques of it. So what is this task force on tremor? This is a group of international investigators, clinical researchers who are experts in tremor. And these are people from Yale University, Yale School of Public Health. They are from the National Institute of Neurological Disorders and Stroke. They are from University College in London. These are people that basically are really, really in the thick of understanding tremor and movement disorders. Now, this just came out, this updated consensus, a few months ago. And the reason they did this was to update the original consensus statement that came out in 1998. And this was the very first criteria that set forth the classifications for tremor disorders. And so they really established what are the check boxes that you have to fill in order to be diagnosed with things like classical essential tremor, dystonic tremor, cerebellar tremor, drug-induced tremor, tremor and peripheral neuropathies. They basically set forth what are the criteria that your doctors use to say, okay, this is what I think it is, and this is what I think this is. So they talked about medical history, findings from the neurological examination. Now you can imagine this is 1998. So we've had 20 years of people saying, you know what? Science has advanced, research has advanced. Isn't this time for an update? And so basically all of these really smart people about tremor came together and they said, you know what? We really have to get more specific. And the biggest criticism that came out was that things were artificial, that we were putting things in boxes just to kind of make ourselves feel better about what we thought was going on. But really the truth is that tremors are messy and there's a lot that's unknown. So for example, what if someone has multiple kinds of tremor? What if they have tremor that is coming from different parts of the brain? What if they have a tremor that evolves over time? The concern that led to this new consensus is that once we label something, usually that's it. And I have seen this myself. I've seen people misdiagnosed with Parkinson's. I have seen people misdiagnosed with ET. I have even seen someone who thought her doctors told her that she had a stroke, and she then, which she did not, and she just kept telling this to different doctors. And I went back and looked at the original hospital records. She never had a stroke, but for 20 years, she and her doctors have been treating her as if she had a stroke. It's just this weird phenomenon that happens in medical records. Somehow somebody says it and it gets in there by accident, and it can just be repeated, or it limits the investigation and we don't go further. And this is a big thing I want you to hear about ET, because ET is going to change over time. It's going to change the way it affects you. The tremor is going to change. And a lot of people wind up getting diagnosed with something else. And so we have to always make sure we're not just labeling something and then forgetting about it. Again, this is also worrisome from an advocacy point of view, because you're going to go in and talk about changing symptoms, and if people think you already are in the Parkinson's box, then guess what? They're not going to think that maybe, you have a right to have some of these other symptoms. It also really limits treatment, because if we're just deciding you have this, we're kind of closing our mind to thinking that maybe some advances in medicine might be able to help you. There are so many tremor subtypes and causes. I mean, I have a whole filled up PowerPoint right in front of me, and we could go from all of the different Parkinsonian symptoms. There are toxic exposures, medication effects, cancer drugs, alcohol withdrawal, brain injury, anxiety, stress. Being cold is actually listed as one of the things. Endocrine disorders, encephalitis, infectious disorders, mitochondrial disorders, genetic disorders. It goes on and on and on and on. So the danger is that we don't want to artificially label someone as having something, and then we don't go down the road of further exploration. So in 2018, this task force got together and they basically did a computerized literature search where they went from 2013 to 2015 and used different search terms like tremor, essential tremor, dystonic tremor classification. They made sure that they only looked at human studies, and there was no restrictions on language. So they took any original language that the authors had written in. The first draft of the consensus statement was based on the literature review and comments from these specific members. And then what they did is, over the course of a few different international conferences, they brought it to their colleagues, and people were having email discussions, teleconferences, and basically a lot of people with really, really strong expertise chimed in, and they have a new classification system for tremor. So I want to talk to you about it tonight, and then the article we're going to get to has some respectful criticisms and suggestions about where maybe they got it wrong and where they need to go in the future. So what this new consensus statement says is that there should be a two-axis system for understanding tremor. And on axis 1, this should be your 4 clinical features. And what this involves is the history of the tremor, and I'm going to go into these in detail in a moment, characteristics of the tremor, associated signs, and laboratory tests. Okay, so you're going to get a chance when I'm done to look at this yourself. You can print it out. But the first thing is the historical features. So within that, there are 5 different sub things that they feel like are very important to understand. The first one is age of onset, and they break that down into a few clusters. Then they have, and I can't tell you how important this is as a neuropsychologist, is how did this start, what is the onset, and how has it changed over time? If there is one thing that you can do to help yourself be an advocate, reflect and document how your problem started, and exactly as good as you can how it changed over time. This is absolutely critical. The next one is any past medical history. Then we have family history, and then alcohol and drug sensitivity. As some of you know, a little bit of alcohol can actually calm down a tremor in essential tremor. So that can be a little bit of a chemical kind of a litmus test to see what's going on. The next one is tremor characteristics, and there are 3 issues within that. This is where in the body did the tremor start and how has it changed over time? What are the activation conditions? And I think this one is actually really, really interesting. We basically classify tremor into 2 broad categories, resting tremor and action tremor. And what they have to say in this new classification system is, yes, resting tremor is very clear. That's its own thing. Action tremor, oh my goodness. They have now expanded it into 1, 2, 3, 4, 5, 6, 7, 8 different types of action tremor. So I want you to read this article and see where it is that you fall in. The next one is associated signs. So this is anything else. This is kind of your garbage can. What are your neurological signs? How are your reflexes? How are your nerves? How's your memory? How's your word finding? And other things that we call soft signs. Now this is very nebulous. This is very hard to understand what the authors mean by this, and that is actually one of the criticisms, because it just kind of feels like a waste bin of, yeah, we're not sure, let's just put it in soft signs. The next one is additional laboratory tests. So these are things like your electrophysiology tests, like EMG, structural imaging, SPECT scans, different like biomarkers, things that, taking tissue samples, serum samples, and things like this. So this is axis 1. This is like your clinical description, what exactly has happened and what's going on. Axis 2 is etiology. This is why is it happening? And there are 3 types of etiology: acquired, genetic, or idiopathic. Acquired means somebody has a thyroid disorder and this is why they have a tremor. Genetic is your mom had it, your grandma had it, her 2 sisters have it, you have it. Idiopathic is we have no idea. We're not exactly sure. You don't seem to have any family history. Unfortunately, it looks like you have it. Within tremor, they have identified 6 new categories of syndrome. And the one I want to talk to you about tonight is they have actually split essential tremor up into 2 different subcategories. So this is a big change. So now we have essential tremor and essential tremor plus. And when we get to the criticisms, it's focused on the plus, because a little bit again of like a waste bin, and the concern is that we're going to just kind of leave people there and not do further exploration. So the definition of essential tremor as established by this new international task force is that it is an isolated tremor syndrome of bilateral upper limb extremities, and it is an action tremor. They say you have to have it for at least 3 years, and the justification here is that we want to make sure it's not really something else. You can have it with or without tremor in other locations, and there are no other neurological signs like dystonia or any Parkinsonian symptoms. Within essential tremor plus, we have all of that. Plus, we have additional neurological signs of unknown significance. So the ones they mention in the article are impaired tandem gait. So what this means is if you ask someone to walk and the toes of the back foot touch the heel of the front foot at each step, so basically like that. If you can't do that, that is a concern. This is things like memory impairment. These are things like the cognitive symptoms, okay? They also have proposed some exclusion criteria. So this is if you have an isolated focal tremor. This is voice, this is head. Now this goes against what I was taught, which was that about 20% of folks with ET have a vocal tremor. So they're saying no, that would be considered something else. Go look elsewhere. Orthostatic tremor. This is a rapid tremor in the legs that happens when someone is standing. They're saying this should not be happening in real ET. Task and position specific tremor. This is when you're doing something like writing, something like standing on a ladder, trying to put a nail in the wall. If someone's tremor is of sudden onset and they experience what we call a stepwise deterioration, meaning there's times of doing okay, then really bad, then okay again, then boy, someone seems to really kind of fall apart, then doing okay, kind of like a staircase, that these are signs that this is not essential tremor. So the key is to look more closely at symptoms, to not just say, oh, I see someone with 2 shaking hands, that's essential tremor, and basically walk away and wait 3 years to do something about it. So in the consensus statement, the author said ET presents us with the greatest challenges, that we admit some of our members wanted to just ditch the whole term for ET completely, because really we know this is a collection of symptoms. This is not one uniform neurological disorder. We don't know the genetics, we don't know the biology, we don't know the molecular background. We're not even sure we really understand all the clinical symptoms. So we have to appreciate this is not one thing that we are looking at. So what the authors say in the review article that I am the point of being here with you tonight is they say, you know what, this 2-axis classification system, this is an improvement because we're going to elicit more symptoms. We're going to get doctors understanding all the different presentations, right? Remember those historical features, the associated signs, the tremor characteristics. We're going to have them doing more physiology lab tests to figure this out and not just being kind of lumpers and clumpers. But they are very, very clear to say that this is just a placeholder. This is just good enough for now, and let's not wait another 20 years before we get to the next stage of understanding what's really going on. He had one of his bigger beefs with the 3-year rule, which the authors felt like is an arbitrary cutoff. There's no biological support for that decision. The idea is you're waiting to see if it evolves into something else, but what's happening within those 3 years? Are we losing a window of opportunity to intervene? You know, we know almost all neurodegenerative issues benefit from early treatment. Dopamine treatment for Parkinson's maybe being the one exception that we commonly think of now. The earlier you start to use it, the less effective it actually becomes over time. But, you know, they're two different things. They also emphasize the term that essential is misleading. If you use the word essential, they say it's like you should only have a tremor and you're not going to appreciate the non-motor symptoms, the mood changes, the cognitive symptoms, and you're not going to appreciate that maybe tremor also is happening in other parts of the body. They really want it to be established that essential tremor is a syndrome, and syndrome always means it's going to have multiple parts. It's not just going to be tremor. They also said that they appreciate the distinction between ET and ET+, but that let's not let that be a slippery slope of just throwing people away with an ET+ diagnosis. Historically, this is where we put things we don't understand. We use it in Parkinson's all the time. We have a whole list of Parkinson's plus syndromes, and what they're concerned about is what are we basing this on? The consensus says we should base it on soft signs, but they don't give us any guidelines for that. What is mild memory impairment to one person might not be to another person. Subtle body posturing that might mean a dystonia to one doctor might not meet that criteria to another doctor. So they really did not reach a consensus on how to define ET+, and so they appreciate that this is good to say these people are not really fitting in the category of ET, but they just want to be very, very clear that this actually should mean that we are uncertain. We don't want to have a false sense of certainty that we know is going on with these people. So they actually prefer the term indeterminate tremor syndrome, and that kind of leaves it open to the idea that we have more work to do. And they really made the point that why this is so important is what if the tremor is coming from something that is genetic, like an ataxia syndrome, a spinocerebellar ataxia 12, and this is very relevant for family planning, genetic testing. We don't have time to waste. We don't want to just dilly-dally for 3 years while we're trying to figure it out. Okay, so in the end, they say ET is a good enough term for now, but let's all remember that we really have a lot of growth to do in this field. We really need a lot more research money coming in. It is the most common neurological syndrome, so we really need to fund it. And you know, one thing I thought was really sweet and cool was when I was looking at where all this research was done, and actually I'll go back in my PowerPoint so I can tell you, almost all of them came from neurology clinics that were named after, like it had been a philanthropical donation. And so these were places, so for example, the Gardner Family Center for Parkinson's Disease and Movement Disorders for the Department of Neurology at the University of Cincinnati, the Edmund J. Saffer Program in Parkinson's Disease, the Morton and Gloria Schulman Movement Disorders Clinic. There's a lot of heart and soul in movement disorders. Just like I said at the beginning, I get so much love from you guys when I do these lectures because I think you're just out there dying for information. So I am going to focus in my next lecture on this essential tremor plus because this was new to me. I got to look into this. So these lectures give me a great excuse to go do a little bit of research. If this talk was helpful for you tonight, I would so appreciate your comments. I would really appreciate you helping me get this information out there. That is why I put the energy and heart and soul into doing these lectures because I really want people to be more well informed, to have objective sources for science-based brain health news. If we aren't in this conversation as doctors, as scientists, I'm afraid that the marketers are going to get in there and you guys are subject to hearing false information and buying products that aren't really going to work. Really, what you really need is good, solid information. That is the heart and soul of good brain health care, education, and empowerment. So I will not be here next week. I'm actually going to be on vacation, but the next week, the next Wednesday, I'll be back and I will talk about Essential Tremor Plus. So again, let me know if you thought that this was good. I hope that I did justice to a very important topic. Thank you guys so much, and I'll see you next time. Bye.